Can you get it? Copaxone, Rebif, Avonex, and Betaseron are available through manufacturer or through the drug wholesaler I call up. Actually, that's where I got the numbers on a couple slides down the way. You can get it readily. It can be in most pharmacies overnight or the next day. You order it today, I'll have it tomorrow. Okay. Tysabri, though, is a special case, and Tysabri, you have to go through the touch program. And nobody really knows much about that except the one pharmacy that dispenses. Tysabri. 9/17, so this was just a couple weeks ago, we have a report. This is interesting. FDA continues to receive reports of progressive multifocal leukoencephalopathy, PML, in patients receiving Tysabri. Let's jump down. Blah, 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 blah. You know, it kills people, but it only kills MS patients. It doesn't kill Crohn's patients. But the final line, or the final sentence, I guess, the risk for developing PML appears to increase with the number of Tysabri infusions received. Why? I mean, why would you do this to yourself? If you get close to, I believe the number was somewhere around 24. You get to 24 and you're going to develop this really nasty disease and probably die. As you can probably tell by my presentation, I am not a big proponent of the crab drugs. Can you afford it? Okay, this data was picked up in the middle of last month. I don't know how much or how accurate it is. If you know anything about drug costs, they change on a daily basis. But Copaxone's $2,600 for a unit of use. Now, this not necessarily means that you're going to get a month out of it or you're going to get 2 months out of it. This necessarily means that however much time you are going to get out of it, you better have pretty close to $3,000 in your pocket in order to purchase these drugs. Now, these drugs, again, if you look at it, the best one, okay, or the best ones are 38%, and that's Copaxone. 38% of their patient population hasn't had an exacerbation in greater than 2 years, I think, their data. Okay, so this is an expensive therapy. We're not talking, I mean, I'm a pharmacist, but I don't think I could fork out $3,000 every month for this stuff. Yeah, maybe Obama will give it to me. Okay, does it work? Class 1 types of evidence means that according to the powers that be, it works, or at least the FDA says it works. So all 4 of them are Class 1 drugs. Again, I don't go into Tysabri because I would really not recommend that to anybody. Injections, the flu-like symptoms. This is the one that I love. Flu-like symptoms. You're either going to get sick once a week, twice a week, or 3 times a week, and you're really going to get sick for the most part. There are a lot of people who get sick, and that's actually why they come off of their drug. So they start looking around for things, and they come across low-dose naltrexone, and the first thing they say, well, why haven't I heard about this? I don't know. Second thing is site reactions. I actually saw a site reaction. As pharmacists, we don't see these sorts of things. People don't come in and show it to us, but this lady did come in and show it to us, and it was a welt about that big, and it was disgusting. I mean, it's the reason why I didn't go to medical school, because you had to look at this disgusting stuff, and it was disgusting. Another thing that they don't tell you is that after 3 years, most of the interferons have antibodies built up against them. So those, and Copaxone, forget about Copaxone because it's not an interferon, but the interferon drugs, okay, stop working in 3 years. I question why most of the clinical studies that were done on these were done in 2 years and not 4 years. 4 years, you would have seen the antibody build up. 2 years, you won't see it because it's 3 years when the antibodies start to build up. Is it easy? No. Is it easy to use? Injection. That's a take-home thing. Imagine injecting yourself. I can't. Okay. Novel treatment. Some of these things I'm going to repeat over and over again because I think they're really good take-home messages. There is growing evidence suggesting a tight cross-regulation between the neuroendocrine and the immune system. Okay, so your beta endorphins and those cells that I was talking about before, there's a tight correlation there. We all know that beta endorphin is an opiate peptide, but some of the things that we don't know, it modulates for pain, food consumption, endocrine secretion, and for immunomodulating effects. There was also a thing out there a couple of years ago where it was going to help with smoking. I take 4.5 milligrams a night, and it hasn't helped me with my smoking, unfortunately. Okay, so this beta endorphins or the BEs have several different effects on the immune system. Okay, inhibitory effects on the immune system. This is from several different studies, and I've referenced it at the end. There's a decrease in levels of beta endorphins in MS patients compared to as standard. The things that it suppresses peripheral lymphocytic proliferation, inhibits natural killers, suppresses IL-2, suppresses IFN production. All of those things that have an inflammatory process as part of it. Not only can bees regulate cytokine pattern secretions, the different types of cytokines that we're talking about, it will also inhibit those T cells, those T1 cells that we were talking early about. Okay, this is real data. This came out of the Italian study, the last Italian study. Okay, BE levels in patients with stable MS and the basal levels of patients selected for enrollment were not significantly different. Okay, so there wasn't a significantly different beta endorphin levels between the stable MS patients and the patients who were selected. That was as control. There's a steep rise, okay, in beta endorphin concentrations in young healthy subjects, okay, where the highest incidence of autoimmune disease happens. And like I said before, this is probably a downregulation versus anything else. But it lags, just like anything else. You know, you catch a cold and you don't start coughing for 24 hours or something. Significantly higher B levels during worsening and clinical relapsing patients. Again, you're getting this inflammatory process and the body is kicking in with the BEs. Okay. Soon after a relapse, again, control mechanisms to downregulate. The beta endorphin concentrations obtained from MS patients were significantly lower than those in the healthy controls. So people with MS have lower beta endorphins. Take-home message. That's what all this means. Okay, now we're going to get into some funkadelic statistics. Patients with MS, stable MS, okay, were lower than matched normal subjects. Okay, so even though you have MS, compared to your controlled group, okay, the normal healthy, 35-year-old white prisoner in camp, those people, okay, if you have MS and you're matched, same age, same gender, I don't think there are many prisoners, but whatever. When they match those two, the healthy MS patients have a lower than the normal patients, okay? So once again, we have more information that says that the beta endorphins in an MS population is going to be lower. Relapsing remitting type didn't differ that much from the control subjects. Now, what does that mean? Is that an active disease? Is it, in fact, relapsing, remitting, moving up and down, and you become normal and then abnormal, then normal and then abnormal? We don't know. Again, the take-home message is concentrations.